Thank you for joining today's webinar. Today is a webinar presented by the Western Regional Alliance for Pediatric Emergency Management. The topic for today is the AzCHER and AMR Phoenix Behavioral Health Facility Evacuation. We have two guest speakers for you. My name is Chris McCarthy. I'm the Arizona coordinator for RAPM. Before we begin, just a quick disclosure regarding the funding sources for RAPM, and a reminder that the opinions expressed here today are those of their author and not of RAPM or its funding source. I'm going to introduce our speakers for today. First, we have Mr. Ben Fagerlie. He's the Director of Operations for AMR Central Arizona, overseeing the deployment of over 130 ambulances in both metropolitan and rural areas. Entering the emergency medical services industry in 2006, he has a background in firefighting, EMS response, and interfacility transport. While still certified as a paramedic, Ben has been in leadership at AMR for over 10 years. And then our second guest speaker today is Robin Oothoudt. She is the executive director of the Arizona Coalition for Healthcare Emergency Response, also referred to as AzCHER. She is a certified healthcare emergency manager and a registered sanitarian with a background in public health, emergency preparedness, environmental health, and pharmacy. I'm going to turn it over to Ben for the first segment. Thank you, Ben.
Thank you, Chris. Today, I really want to go over a way of thinking about facility evacuations that I haven't seen covered in a lot of detail in any of the pre-plans that I've been a part of, or in the facility evacuations that I've had the opportunity to engage in from the transport side. There will be a lot of stuff that's fairly obvious, but hopefully you'll be able to take some things away from this presentation to help you consider some of the challenges in moving patients from a facility to another location during an emergency or during a planned evacuation. So I like to break the facility evacuation into two different types. There's either an emergent evacuation or a non-emergent evacuation. And emergent evacuations can vary in their scope and scale, just as non-emergent evacuations can. Pictured here is a hospital fire that's resulted in the evacuation of a maternity ward. So it may not be a full facility evacuation in either case, or it might be a single floor, a single wing, a single tower, or a full facility. Some of the defining characteristics of an emergent evacuation are that they are presenting an immediate danger to the life and health of the patients and or the facility staff. This is we have to move patients now, or there will be serious consequences, and we're going to take much higher risks as we move them to get them away from the danger. The initial evacuation may be simply to the parking lot of your facility, might be across the street. It might be just get them out of the building or get them into a different wing until we can move them later. Most emergent evacuations are going to be a multi-agency response. So this will be a 911 call where you have fire department and police coming to help you, and they're going to be at the top of the incident command structure, taking control of everything, and your staff members are going to slot into different places in that structure to assist, whether that's with a triage and treatment, giving advice, or just helping move these patients outside of your facility. But the incident commander initially is likely going to be somebody from a fire department or potentially even the National Guard. These events are pretty easy to imagine, and that's what I have seen most people planning for. So some of them are going to be unexpected events that just change everything that you thought about what your evacuation plan could or should be. Pictured here, we have an example of a flood that forced an evacuation onto the roof, and the National Guard was called in to evacuate people by helicopter from the roof of this hospital. Something that hopefully we don't have to encounter, but is a real potential issue, is a terrorist attack, whether it's chemical, biological, or something of that nature, that's going to require decontamination of patients as they come out of the facility. On the right side of the screen pictured is a drill that we did with the local hospital for evacuating patients and deconning them as they come out. So these are the obvious ones, right? These are the fires we have to get out now, and we need as much help as we're able to get. A non-emergent evacuation is a completely different animal. In most of these, there is time pressure. There is a deadline. There is some time where we have to move these patients by, but whether it happens now or in an hour is really immaterial, as long as we get everyone out by whatever deadline is set. Many of these evacuations are not going to involve many other agencies, likely not going to involve the police department for crowd control or shutting down streets for landing zones or anything like that. They may not involve the fire department, depending on whether you have a municipal transport agency or private transport agency. The person running these evacuations is probably going to be somebody from your staff. And almost all of the incident command structure is going to be filled by people inside the facility. Another thing to consider is that a lot of these evacuations, these are more of an interfacility transfer than a mass casualty incident. So the placement of these patients can be very difficult. A local facility is likely to open their doors and accept as many patients as you have to send them if your facility is on fire. But if you're moving 30 patients because your AC went down, they're likely going to say, we can take this many, and you're going to have to find placement from there. That might include calling report, finding an accepting physician, might involve EMTALA transfer paperwork and that type of thing. So this is a completely different animal, but in my experience, it's much more common, thankfully, because it gives us a little bit of time to figure out a game plan as we go. So I've seen every one of these listed causes for a non-emergent evacuation, whether it's an HVAC failure. Here in Arizona, the biggest issue is heat, but in other parts of the country, heating failure is going to be just as big of a problem. An oxygen system failure. Water and electrical system failures are interesting. I've seen multiple different kinds of failures in facilities that required evacuation, whether that's contaminated water, which Robin will be going over an event that warranted an evacuation of a hospital due to that, or a complete water system failure where there's nothing coming out of the taps. Electrical system failures of all kinds, whether it's backup generators failing during a power outage, backup generators only powering part of the facility, requiring an evacuation of certain parts and not others. Something that's really seems to have kicked up a lot in the last several years is preemptive evacuations for wildfires. So somebody at the state or national level comes to the facility and says, hey, we think the fire is going to be here around tomorrow at 3 p.m. You need to get everybody out. Maybe it reaches you, maybe it doesn't, but there's a lot more wildfires happening across the Western United States with a lot higher intensity. And this is just anecdotally my experience. The tolerance for risk seems to have gone down quite a bit. And the number of evacuations due to these wildfires are increasing. Whether that is due to the intensity or the risk tolerance, I'm not sure. Severe weather events might be the single most common across the nation, and this is specific to hurricanes. We know a hurricane's coming. We're going to get everybody out of this facility and move them into an area outside of the path of the hurricane until it passes, and then move them back. We don't have to worry about that as much here, but every year AMR sends people over to the East Coast to move people out of Florida nursing homes, out of Louisiana or Georgia nursing homes and hospitals, move them into a safer location, and then move them back. Where this really starts to get complicated is when you are a specialty facility, and the more critical your patients are, or the more specialized your facility is, the harder it is to find placement for these patient populations. Obviously, pediatric facilities as the predominant group of people here at this webinar. But even amongst pediatric patients, there's a wide range of acuity. So if you are a pediatric ICU, you are going to have a much harder time finding placement for your patients than just a general pediatric facility or long-term care facility, or even an ER. If you are a neonatal ICU, you are going to have an even harder time than just a general PICU. So ventilators and medications are something that I do not see pre-planned for very often in the facilities that I've involved in evacuating. So this comes into the transport considerations here. Where are you going to send these patients that can accommodate the ventilators or the medications, and how are you going to get them there? Your local transport agency may or may not be able to accommodate the transport and movement of the patients that you need to move. The level of service of each agency around you should be considered. A BLS ambulance with 2 EMTs on it cannot move your ventilated patient. That's outside of their scope of practice. It can't be done. A lot of agencies with ALS units also don't have a ventilator capability and would require a critical care paramedic or a critical care nurse to run that ventilator. So as you're pre-planning for where am I going to move these patients if the worst were to happen, something to consider is, do we have to fly the majority of these patients? If we do, how are we going to land the requisite number of helicopters? Are there agencies surrounding our area that we could call in for mutual aid to come assist us moving these critical care patients? Work with your local agencies to answer some of those questions before you get into a situation where you need to find out whether or not they can run a vent with a PEEP of 8, or if they just have a simple transport ventilator that does rate and volume and doesn't go below a 20 kilogram patient. AzCHER, or the Arizona Coalition for Healthcare Emergency Response, has been an absolute godsend to us here in Arizona. They are the single best resource that I have ever seen for connecting people with needs to the solutions at an administrative level. So if you are in Arizona and you have questions and you're not a member of AzCHER, I highly recommend that you become a member and start utilizing them to help answer some of these questions. I have done facility evacuations before AzCHER had really taken off and didn't have much membership, didn't have much involvement in the healthcare community in Arizona, and I've done them after, and it is night and day. AzCHER provides us with an opportunity to do agency drills, and when we run into specific issues like patient placement, they have the ability to send text, emails, and phone calls to the entire membership asking for help. So if we need to place 12 pediatric patients on ventilators somewhere else, please send in your response on whether or not you can accommodate and how many. And the partner agencies with AzCHER have been very responsive to that, and it's been amazing to watch how fast we can get patients placed and then moved to the appropriate areas through this agency. So if you're in another state that doesn't have something similar, that's something just to consider. How do we get a single agency to coordinate across the state find answers to these problems. I think COVID really pushed people to join this, because moving patients during COVID, as most of you know, was a absolute nightmare. It was very difficult to find bed placement, and I think it really showed the need for one agency to kind of be a hub for everyone else to be involved in. They also have set up status report meetings during facility evacuations. So every few hours, everyone involved can come together, even if they're not part of the incident command structure, or if they're not needed yet but might be, and give an answer on, hey, we have this many resources able to respond, or we have this many beds if you need them, and it's just been a real game changer in this type of event. So as you are planning for facility evacuations, as you are starting to develop a plan, hopefully for both emergent and non-emergent evacuations, I would start with the most critical patients that you have. How would you move them? Where would you move them to? In an emergent situation, those are treated more like a mass casualty incidents, where local ERs open their doors and get them here and we'll sort it out. But if you have a planned outage of your oxygen system as it's replumbed to fix the leaks, and you're going to be out of commission for 2 weeks, and you need to move all of your patients out and then back, where are you going to move them to for that time period? What facilities around you are able to accept them, and how many? How many could you accept if a facility near you were to call and say the same question back to you, both in a mass casualty incident scenario and in a short or long-term placement scenario? Who at your facility is going to be the one who is coordinating all of this? How are you going to track which patient is going where, who's taking them, have they gone yet, and when are they coming back? I've evacuated, I tried to count them up. I couldn't remember everything, but I think I'm over a dozen facilities that have been directly involved in evacuating in various capacities. And the biggest things that I've seen is that pre-planning those critical patients will make the entire process so much easier for everyone involved. I was part of a evacuation of 16 vented patients out of one facility, and that went very smoothly because they knew what they were going to do with their patients. They knew that these were difficult patients to manage, to transport, and to find placement for, and they were ready for it. So that evacuation actually went very well. It was very smooth, very easy. Second, know where to find help. If you're in Arizona, I'm going to push AzCHER every chance I get. They've been a wonderful partner for everyone across the state, and they're the ones that I would go to if we were suddenly in need of help, because they can part out that question to all of the experts and all of the resources around you without you having to make a dozen phone calls. If you don't have something like AzCHER, I would encourage you to see if you can at least get involved with the facilities and the agencies around you to try to get ahead of this. Figure out what would you do. Do some multi-agency drills. Do some mock evacuations. Work together to problem solve before you actually have the problem. And then the last thing I would say is, as you are evacuating your facility, involve the transport agencies in your incident command structure on non-emergent evacuations. They are going to be the ones doing the work moving these patients. Have them as a transport sector in your command center so that they can assist you and let you know, this is the timeline on getting there and back. This is how far our ambulances can go with a ventilated patient before they run out of oxygen. You're going to need to fly them. If you're going to be flying a lot of patients and you know that, get a base manager or a base director involved. They know their system, they know their capabilities, they know what they can do for you, and they can answer those questions and real-time solve your problems from inside your facility. So with that, I will turn it back over to Chris or Robin.
Thank you. And Ben, thank you so much for that great pitch for AzCHER. We appreciate that immensely. So I'm Robin Oothoudt, and I'm the Executive Director of the Arizona Coalition for Healthcare Emergency Response. We are a single coalition. We are one of the few that is statewide. We are divided into 4 regions, kind of somewhat geographically similar regions. We have over 1,000 member facilities. We have additional partners, county and tribal public health, emergency management, other kinds of organizations, CERT teams, MRC, and service providers like Poison Control, Donor Network. We even have some support like Border Patrol Agency. We have APS, Grand Canyon University. So there's a lot of different variety there. Waiting for, there it goes. Okay. So one of our yearly things that we have to do is a hazard vulnerability assessment. And this particular year, this is the 24-25 assessment. In 3 out of the 4 regions, extreme heat came in as the #1 hazard for Arizona. In the northern region, it was a little bit different. In fact, did not fall into the top 5 at all, but that's because the northern region is pretty much is mostly made up of high country and is definitely cooler there. All of our exercises and a lot of our trainings are based on those hazards. So we work around those every single year. They do change every year. During COVID, obviously, all of a sudden infectious disease was up there in the top 5, and it hadn't been before. So things that are going on at any given time might change what that hazard vulnerability comes out to. There it is. So, like I say, we base everything we do on the hazard vulnerability assessment, and that includes our statewide exercise, which we did during our final year of the last budget, or the last cooperative agreement with HPP. So over that 6-month period, we developed a functional / full-scale exercise. It's delivered virtually, so the facilities themselves can determine whether they're going to play it virtually or play it functional or full scale. It's up to them. We're delivering the whole exercise to them either way. In this particular exercise, we teamed up with FEMA's National Exercise Division, who I can totally promote. They were fantastic to work with. They were free, so that saved us about $100,000 on a consultant. So way worth doing this. They were great to work with. We had 236 facilities participated in the exercise, with over 2,600 individual players. So part of the scenarios that we laid out, and we laid them out a little bit different for each of the regions. So for the central region, and that's the area where this behavioral health facility is located, we had HVAC failure during a heat issue that would require the hospitals planning to either decompress to take on new patients or to evacuate the facility. And same thing, we played that in the central region. Southern region had wildfires and power supply problems. The northern region had fiber optic issues and infrastructure issues. And then the western region had heat and wildland fire. The facility that evacuated, this behavioral health facility, had taken part in this exercise as an evacuating facility. This was in May of 2024. So they practiced in May on how to do this. So some of the after action that we came out with from that particular exercise, establishing structured, secure, and efficient communication channels. Communications are always going to be on the top of the list for, things that need to be worked on. Continuous review and update of our resource requests. We have 15 counties, and each county has a different program for how they want a resource request to go through. So that, gets a little bit confusing sometimes. Develop and disseminate standardized facility checklists. That came out to be something that we ended up using in the actual real events was, hey, what do we want to know here? Promoting integration of the Ready, Set, Go program. We had facilities who were told at the beginning of the exercise that they were in set status for a fire, and complained that there wasn't enough for them to do. As far as we are concerned, if you're in set status for a fire, you have 1,000,012 things to do. All right, and then we had to design some adaptable evacuation protocol for home health based and those in transition. That's kind of a left out category, but we won't go into that for this. So knowing that they practiced this ahead of time, last year was an incredible year for weather in Arizona. We had 113 days that went over 100 degrees. We had 70 days that went over 110 degrees, and that beat the records all over the place. We went 150 days during that year without a drop of rain at the airport. So it was definitely a hot, dry year. So on August 8th, it was 109 degrees, and that actually is a standard Phoenix summer day. Nothing unusual about that. We were looking at that particular next couple of days going over the 110 mark, and that's going to start triggering some extreme heat warnings and a little bit of issue for people there. So going on to this incident, this was August 8th of 2024. At around 5 o'clock, the behavioral health facility experienced a catastrophic cooling system failure. And the outdoor temperature was 109 degrees. They immediately came in and brought chillers, portable chillers, to try to keep the units cool. They kind of consolidated what patients they could. That's a little bit tricky. Actually, that's a lot tricky in a behavioral health hospital. Despite those efforts, the temperature was up to 97 degrees inside. CMS does require indoor temperatures to remain between 72 and 78 degrees for a hospital facility. The parts that were needed to repair this system were coming from Los Angeles. It was going to take a couple of days. Then there was the installation time, and the temperature was increasing over 110 for the next few days. At this time, they had 90 patients. 10 of them were court-ordered, and 22 of them were between the ages of 5 and 17. So roughly 8 o'clock that evening, they decided they were going to have to evacuate some patients. They needed to get the coolers who they could into smaller areas. So they originally planned to just decompress. They wanted to get a few patients out the door. They sent 10 of their patients over to a sister facility as a start. And that happened, that first evening. They would transfer a couple of more during the night. But right there at 8 o'clock, that security manager who had practiced this in May during the exercise knew he needed to call us. So he called our warm line, which is available there 24/7. Myself and the 3 regional managers take turns manning it as the duty officer. And that particular night, it was my turn, so I got the call. And they let us know that their cooling system had failed, that they'd put up portable units, but that it was not cooling sufficiently. So we activated at a tier 3 in our emergency response plans because we knew this was going to have some regional impacts. If you've got a lot of patients, especially specialty patients, everybody's going to be involved. So at 8 minutes after 8, we sent a request for behavioral health bed availability to our member hospitals through the Arizona Health Alert Network. And at that time, we actually did only go for the behavioral health facilities. And that was based on what the facility itself wanted us to do. We give them a lot of options. Do you want us to contact everybody? Do you want us to just go for behavioral health? So they chose behavioral health at that point. So by 12 minutes after 8, we had sent notifications already to ADHS, Maricopa County Public Health and Emergency Management, the City of Phoenix, Phoenix Fire, the Arizona Department of Emergency and Military Affairs, and multiple hospitals within the region. By 9 o'clock, we had utilized the MS Teams chat and had an MS Teams platform stood up so that everybody could join into that one location, that one platform for situational awareness calls. And they could put situational awareness updates into the chat if they occur in between calls. So you didn't have to wait until the call was made to put the information in there. you could just put it into the chat and it would automatically go out to everybody as an immediate notice. So we sent messages out at 2020 and putting out, more needs for beds, what's available. Please give us a call, let us know what you have. Call the facility. We had a contact at the facility saying they need immediate bed availability, and to contact this particular person to give them what they had. And they were immediately receiving multiple calls. And that health alert, really conveys that that's the highest level of importance. We use the health alert when it's, we don't use it for anything that's not really, really important. If it's coming in emails rather than health alert, it's not as emergent. So setting up our communications on the Microsoft Teams worked out really, really well. Our Central Region Manager, Jamie, activated the Teams dashboard, and that allowed us to communicate with everybody all at one time, our community partners and our liaison from the facility that was evacuating. The first situational awareness meeting was held at 10:30 that night. And amazingly, we had representatives from County Public Health and the city and the fire department. We had almost everybody we needed online at 10:30 p.m., which was really surprising. Jamie and I were up until about 2 o'clock that morning, following the updates and stuff that were going on chat, and making sure that we were available if we were needed during the night. So some of the pros to that, everybody getting on the same spot, you can have the information that's available at any time because it's right there. The community partner access, almost everybody has access to Teams, although we did find there were a couple of facilities that are restricted on what they can have in terms of Teams. Some of the challenges, those were the people who needed IT for support for that. And then there's a little bit of a learning curve for new users for Teams. So some of the things that went through the chat that night, showing 10 patients were transferred to the sister facility. Clinical leaders are actively working on getting other patients transferred to other facilities. The Maricopa County Department of Emergency Management notified Tool Bank, which went to voicemail. That's always an issue, but they did reach out to the Red Cross for portable ACs. Valleywise is another hospital, and they actually sent their HVAC staff to help with the repairs. The VA was asking to, any veterans evacuating, will take them. The VA also offered up their buses for transport, which at first we thought was great. We kind of learned a little bit about that later. So yeah, they had 2 really great buses that we found out we couldn't use. I'll explain that a little bit. Our COADs had 20 portable chillers ready to go, just needed to get them deployed. EM Resource is a tool that's the state supplies. Hospitals are not required to use it. Most of them do use it at least some of the time. It's some hospitals update all the time, some hospitals update occasionally, but it has psychiatric bed statuses in there. So we requested the facilities to update those statuses and provide us with any notes within the comment section, like, yeah, we have the beds, but we don't have any staff for them, whatever the case may be, but that we use the messaging for that reason. So in the first 24 hours, they had transferred 12 patients overnight. They continued to send some transfers out, but transportation was becoming an issue, trying to figure out how to coordinate all of that. Maricopa County Department of Public Health delivered portable chillers. City of Phoenix delivered portable chillers. We didn't know the airport had great big ones. They offered those up. The facilities had gathered patients into 2 small areas, and they were attempting to keep somewhat normal operations during this time. Keeping in mind that those portable chillers were in just a couple of areas and on the patients, and were lacking in other areas of the facility. So the staff was actually suffering pretty badly in the heat. And then we'll talk a little bit more about that transportation here in a second. So we had our situational awareness briefings. The next morning, we had our first one, I think it was at 9 o'clock. The meeting updates, we asked the hospital liaison to let us know if there had been any patients discharged, how many were left to be transported, how many patients were in-house, what was the diversion status, current temperature, and so on. One of the things they were saying that morning is, hey, we think we've got them, into these two areas. We may not need to move anymore. We're going to try to keep normal operations. We said, okay, let's meet again at 1 o'clock and we'll see what's going on there. And they're hoping to keep at 1 o'clock. They're still hoping to keep those remaining patients in the facility. They didn't want to move them away at that point, thinking that, yeah, we've got things kind of cooled off, and yeah, we've got them all cohorted into a couple of different areas. And then at 1600, licensing showed up and ordered that all patients be evacuated. Everybody had to go. And at this point, we asked, well, actually, AMR offered to put a supervisor on site in the EOC at the facility to help figure out those logistics of the transport. And what a godsend that was. I mean, I can't say more about how much they helped the situation for this. They were fantastic to work with. They did a great job in there. They even brought EMS supplies from other counties. They brought ambulances from other counties in order to move patients without disrupting patient movement, the normal patient movement in the Phoenix area, which is pretty big time anyway. So they were great to work with. Current temperature inside the facility at that time was 95 degrees. So in two of their units, they did have some areas that were somewhat compliant. That was their term, somewhat compliant. So the timeline for the recovery still was Saturday, was going to take 8 to 9 hours to set up, and then there would be a time for cool down. So at 1600, licensing ordered all the patients evacuated and all the walk-in patients had to be diverted. More ambulances were brought in, also from other counties to assist. Emergency managers and public health from surrounding counties also joined into the coordination group. They were listening in on the situational awareness calls. They offered up their support, portable chillers, anything else that they could do. The evening situational call, which occurred around, I think we met on that one at like 5 or 6 that evening, that the evacuation was actually going well. Our calls for beds from the night before were actually, we didn't even have to call for more beds because they got so many offers for beds the night before. They were able to keep taking up, just to take advantage of those on Friday. So when they realized they had to completely evacuate, they actually already had enough offers for beds to go with, which is, to me, phenomenal, because I know, behavioral health is a hard one, and especially when you have also juvenile patients who need to be transported. So that situational awareness briefing, our last one, was on Saturday morning, August 10th at 9:30 in the morning. We had a updated discussion of the patients returning. We had the last patient transported at 5:30 that morning. The HVAC parts were being delivered by 8 o'clock, and repairs were going to take about 8 hours. So they demobbed all the cooling equipment that had been offered up by the city and the county and so on. All of that was picked up and returned to their districts. AMR returned their units to their own districts. And we kind of, shut the door on this. We said, okay, we'll wait and see, when it's time to come back, what's going to happen there. So we terminated our coordination and our situational awareness meetings. However, the facility was not allowed to reopen. They did try to reopen the next morning after things had cooled off somewhat. They opened for walk-in patients, and that licensing showed up at that point and said, no, you're not reopening. They gave them a court date to appear at, I think it was 2 or 3 weeks later, and they were denied their license opening at that time as well. So the patients never came back. So some of the best practices that came out of this, the coalition assisting in the coordinating was really great. We served as a liaison and a common repository for information exchange. And key component here is we have the contacts for almost anybody you might need. Teams provided an easy to access platform. The chat feature allowed us to update as often and as much as needed. The private ambulance service providing the coordination was absolutely excellent, and we will ask for that pretty much anytime we have this happen. Our annual resource gap analysis and shareable inventory. we know now we need to have a better one. So it not only would it be a best practice, but it's also a gap. And then we have pre-signed MOUs. So everybody, almost everybody who is a member of AzCHER, and it's free membership, can sign an MOU with us. And it doesn't, legally obligate you to anything. It just says that, hey, if we have the availability of helping the guy next door who needs help, we'll do that. And you'll work out between you, if there's a cost involved or anything like that, that's worked out between the two facilities. So part of our after action, that Teams chat access allowed the link to continue accessing chat even after the meetings. We were still getting notices on our phones and through chat online to keep up with what was going on. The transportation coordination, we have limited visibility of available transport resources, so having them in-house absolutely was a fantastic thing. Behavioral health training, this was a biggie for us. All of your cooperators don't have this clinical training, and that was very much needed. And we did end up having a training conducted by the licensing department that taught us a huge amount of new things. So now we have a little bit better idea of the standards of care for behavioral health. Note-taking, it wasn't really note-taking. It really kind of came out as we needed to have more of a dashboard to keep track of how many patients were transported already, how many beds were needed, what kind of beds were needed, so on and so forth. And where were they? We ended up using that in the Tuba City event, which I'll talk about here in a second. And then resource availability. Partners inquired about heat-related relief supplies for future events, and we learned about a whole lot of supplies we didn't know were out there and that we need to find out about and have a better statewide record of what's available. So one of the best things that came out of this whole event was a functional work group on hospital evacuation. This event took 36 hours to get all of the patients moved. So obviously a non-emergent event. However, what if the building was on fire? Then what would we have done? How would this have happened? This, the specialty patients and so on, what would have changed? So we now have a working group made up of multiple hospital members, community partners, AzCHER. We meet on a monthly basis, and we are creating a plan that's first going to be in the Maricopa County area where the bigger hospital locations are, and eventually we'll put it out statewide. But it's a plan for how to run an event just like this. Where do you stage the patients when it's over 110 degrees outside? Who's the main coordination? Where's transportation coming from? How staff and patients are protected from the heat? There's a lot of things to consider on that, and we are actively working on that as a group. And then we had another evacuation. So on April 21st, we had Tuba City Regional Healthcare had a critical water contamination event that occurred actually related to their HVAC system. The propylene glycol line that cools the air for their system actually backed up into their freshwater system, contaminated the entire thing. So they called, so they had an urgent request to assist with evacuating 32 patients. We got all the partners on the line: public health, emergency management, tribal emergency management, and public health, as well as county. We got AMR on the line. We had Guardian on the line. Everybody was there. Within 4 hours, we had successfully coordinated appropriate receiving facilities for all of the patients, and the complete evacuation took 13 hours, with 15 of those patients being transferred by air. Patients included 3 newborns, 10 isolation patients, 1 continuous EEG monitoring. So it was a little bit crazy. And there were, I believe it was 9 different facilities that received these patients. All right, that's my story. I'm sticking to it.
Well, thank you, Robin and Ben, for these presentations. Lots of information. I particularly love the lessons that both of you learned through lots of experiences, but even just these recent ones that you shared. It really gives us some insights as, like Ben mentioned, these weather events are more and more, the fire events are more and more common, so everybody can benefit from this preparation. So with that, we will move to the Q&A section. Just a reminder, we do have the Q&A feature, but I see some of you use the chat, which we can read from both of them. So I do have a few questions already in for both Robin and Ben. I'm going to start with the first question we have in the Q&A, which is, how did you prioritize who was transported first? That question is for both Ben or Robin.
So that's an interesting one. Typically on an emergent evacuation, or in any mass casualty incident, you're going to be doing something like a start triage, or for pediatrics, maybe a jump start. This behavioral health evacuation, essentially all the patients were walking, talking, no medical complaints. We did have one patient who did have a medical issue during the evacuation, and that patient was transported to an emergency room instead of the behavioral health facility that would have otherwise received them. But from our standpoint, we were transporting them as they got placement. So how that placement triage went is really going to be up to each individual facility. Who's the most critical to move? And I would suggest starting with your hardest patients first, because a patient with a broken arm who's post-op for a fixture or something like that, it's going to be much easier to explain to an ER that you have to evacuate them to than sending them a 9-day-old vented patient. Those are the ones that are tricky. Those are the ones that require special facilities and special equipment, special providers, and they're going to be the hard ones.
In this particular instance, the facility itself did put some emphasis on moving their court-ordered patients first. They were going to be the hardest to place, and that was the emphasis to begin with, was to get them moved.
All right, great answers. I'm going to now bounce over to a question I see in the text chat. What was the longest transport time, seeking the total response time for the most complex patient? And what would you recommend for an average transport time that could be used for planning purposes? Again, open to both of you.
So our longest transport was just over 100 miles. It was, I think, just over 100 miles, about 105, 110 miles. So obviously that round trip is going to be substantially more than taking them to the ER down the street. We got lucky on this one in many ways, because the facility we were evacuating was very centrally located. And I would say the average patient transport was something between 20 and 30 minutes. Then you have the transfer of care time. Then you have the return time for those ambulances. So for this, I would say the average turnaround, we were looking at probably about 90 minutes. This is going to be entirely dependent on where you are. The Tuba City evacuation, due to their water system contamination, many of those transports were 2.5+ hours by ground, which is part of the reason they opted to move so many by air, because a 5+ hour round trip just wasn't going to work for them. So it's going to be situationally dependent, and that's something that I would highly recommend working with your local transport agencies to figure out what is your realistic time on task here. What's your realistic turnaround time if we are moving these patients both in an emergent or non-emergent evacuation?
Yeah, as we coordinated, in the central region, everything's pretty close. Not a big deal. Rural areas are another story. The Tuba City, the nearest hospital is 80 miles away. So it's always going to take a lot of time to move that patient, and transportation is always going to be an issue. So what we do originally, when we start that coordination in those rural areas, is we start with the closest hospitals and try to get as many patients placed as close as possible as we can, so that there's any hope at all for a turnaround for an ambulance. And in some cases there won't be, but that is how we try to do that. So we kind of branch out further and further as we look for beds, but we'll start as close as we can. that one was like nobody was closer than 80 miles. So just worked out that way.
All right. Back to the Q&A. How was patient tracking managed? Was it on the sending hospital side, or did the county or state get involved?
No county or state involvement in that one. That was entirely on the facility themselves.
All right. Straightforward answer. We're going to jump right to the next question. Could you talk about the decision or reason the VA buses were not used? I was curious about this too.
Yes. So we kind of thought that was a fantastic idea, not knowing what those standards of care are. But it takes a much bigger event and a little bit of emergency declarations for you to change the standard of care. So since we didn't have that, it was just an individual facility essentially transferring to other facilities. They had to go by the traditional routes of it, one ambulance per patient kind of thing. Yeah, it was just had to do with the standard of care. So a licensing issue, there has to be some sort of declaration for you to change your standards.
All right. And then I got another one in the Q&A. Were there any issues in finding ligature-resistant rooms or facilities to take in behavioral health patients? Same questions regarding the transport, which I think you just answered. So yeah, just about the room.
Yeah, great question. That would be one that would be entirely on the facility itself. Because we really relied on them to make those arrangements and to get what they actually needed. Unfortunately, there was pretty much a gag order placed on them very quickly after the event, so we weren't able to get that information from them.
Right. And then there was another one in the text here. This goes back to some of the data you shared, Robin, around the HVA. What was the date of data collection that informed the AzCHER statewide hazard vulnerability 24 to 25 results?
24-25 would have been our survey usually goes out in about August, and it's out there for usually a few weeks for facilities to fill it out. That particular one had 113 facilities, I believe, that filled out the information. And then we go through and crunch that data. So it would have been second half of 2024. Or sorry. Yes, second half 2024. I have to think about that for a second.
All right. Okay. And with that, I don't find any more questions in the text chat or the Q&A feature. So with just a couple minutes left, I'd love to give Ben, Robin, any final words that you'd give from your experiences here.
Just kind of same thing that Ben said. If you're not already a member of the coalition and you want to be, go to our website, AzCHER.org. It's free to join. We've got tons and tons of free resources to offer you, and would be happy to welcome you in.
My advice is to do some drills. Get your pre-plan together and work through the process. Do multi-agency drills if that's at all feasible for you. But that will show you what questions need answers. And when it actually happens, because inevitably it will, the answers you came up with are going to be what you're relying on. During an emergency or even during a planned evacuation, that is not the time to be figuring stuff out that you could have figured out months before.
All right. And I appreciate those last words, but it sparked another question. So we've got one last question for you. What would an ideal visibility for transport resources look like? Leave that up to your interpretation.
I would say on our end of things, I would love to see everybody using EM resource because ambulances and such are listed in there, especially the air support. But we could have essentially a whole statewide what's available ambulance-wise showing up in there as well. That would be fantastic. Probably a pipe dream, but fantastic.
Yeah, I think even if we had full visibility into the number, that's still not going to give a good picture of what is available to respond to the incident. Some number of those resources are going to be tied up on the normal traffic that we're required to run. In a true emergency, in a true mass casualty incident where we are evacuating a hospital, for example, that's on fire, then a lot of the services are going to be delayed to other people as we funnel everything we can into the major incident. For something like what we've described, I think the ideal visibility is having somebody from the transport agency sitting in the same room as the incident commander and telling them, we have 4 ambulances on scene. We have 8 that'll be here in the next half hour. We have 12 more coming from outlying areas that'll be here an hour after that. At that point, we'll be getting those first 4 back. So this is how you can start to plan and build out the next few hours of what's going to happen. I don't see that happening without very tight integration with the transport agency. There's just no way you're going to get access to anybody's CAD systems or computer-aided dispatch systems to be able to actually see where they are. But if you have a direct line of communication with the person who does, face-to-face, that's the best way to crack that one.
Awesome. Well, thank you again. I'm going to take this moment as we bring the webinar to a close today to share the QR code for the RAPM website. There is a resource library, contains lots of pediatric focused resources for pre-hospital, hospital, even some of our public health partners out there. So please do visit the RAPM website for resources that can go into some of that planning or even drill activity that Ben mentioned around these evacuations.